Good morning, everyone. Let me know if you can hear. Perfect. Thank you all for joining me this morning. Day before your exam. Let's talk about that today. Start here in just a few minutes. Of course, if you have any questions, please post them up in the chat or on the sticky board and go from there. Early in the morning, but hopefully you guys got some energy. We get some interactions going on here. Want to hear about any questions you have for the exam, because I've not heard a whole lot from you all so far. Either a really good sign or all right, well, in the interest of time, I guess I'll go ahead and get started here. All right, well, welcome back. As you know, your exam is tomorrow, and so as I mentioned, I haven't really heard much from you guys in terms of questions, guys and gals. And so, like I mentioned, that's either a sign that you guys know this stuff pretty well, or at least you feel you do, or either you don't know what you don't know, and so you're not sure what to ask or anything like that. But either way, I highly encourage you to either post up some questions in the chat we can talk about, post them up on the sticky board, or email me as soon as you can, because obviously it's tomorrow morning. So, the sooner you get that to me today, the more likely I am to respond to you. Again, it's over sections, I think 5 through 8. Okay, weeks 5 through 8. So that's a lot of material there. So I want to make sure you guys are set up well to do that. So this section is relatively short, sort of by design, because I want to give you guys some opportunities to ask questions, because as opposed to last time where there was a lot of like fundamental questions on the test, and there was only a small quarter of it roughly that was going over actual medications, like the hematology section. That's like all drugs this time. So all those like case vignettes and application questions are going to pop up there, you know. So we can talk more about that later, but at least let me get through the section here today so you guys can at least get started for the next topics. So this section today is not going to be on the exam for tomorrow, just FYI. So if anyone has questions about that, that is but let's start talking about some endocrinology stuff. So two things this will not cover includes the OB-GYN endocrinology section. That'll be probably next semester, where we're going to talk about estrogen and progesterone and FSH and LH and all that stuff then. And then also we're going to talk about diabetes separately. We'll next semester as well. I think that's when you cover that additionally. But kind of all the other ancillary endocrine topics we'll talk about here, but that's relatively short from a drug perspective. So, but let's get into it. So, real quick topic right up front is hyperprolactinemia. Now, hopefully, you guys have had, some physiologic review of the basics of the endocrine system in terms of how it works, right? So, talking about control from the hypothalamus down to the pituitary gland, and then to whatever effector organs we're then talking about. So whether that be the thyroid gland, whether it be the testicles, whatever it happens to be, and you have to know the concept of the negative feedback loop. Important there. All right, so I'll talk about that in just a moment. So the negative feedback loop is super important to understand in terms of how endocrine function is going to happen here, right? So if I say, for instance, we're dealing with the adrenal glands, right? So we're talking about the release of cortisol. It's like a stress hormone. If I'm supplying exogenous hormone that kind of replaces what your body's naturally producing, that's naturally going to shut down production of that hormone. So, for instance, if I have someone who's taking something like dexamethasone, which is topical in the news if you've been watching, if someone's taking dexamethasone, the body detects that and says, well, I have enough corticosteroids around here. I don't have to produce my own anymore. And so that negative feedback loop has been activated, and it shuts down release of things like ACTH and whatnot that causes shutdown of production of things like cortisol. And so that's how a lot of these systems are going to be working here, and either to replace what we're missing or in order to maybe decrease production of something that we have too much of. So a really important concept to get down for that. So just kind of start thinking about that in terms of how these different medications are working. Alyssa had a question. She said, I was wondering if you always double cover for Pseudomonas, or only if you do in cases where the patient's immunocompromised, failed other treatment, etc. Generally speaking, if we're really worried about a systemic pseudomonal infection, we double cover for it. So we most often think about that in terms of like pneumonia or like sepsis or something like that. In those cases, you want to double cover, because if you don't know what the susceptibilities are for that Pseudomonas, then you want to make sure you cover your bases and go with 2 drugs just to make sure that you don't treat it with something that's going to be more likely to be resistant against. So that's why we double cover, right? So you want to think about what drugs you're going to double cover with. Make sure you're using 2 different mechanisms there. In those cases, once we have your susceptibilities back, and then you can scale it down to whatever it's actually going to be susceptible to. No Dallas is asking, is there a specific first line for Pseudomonas? There are a bunch of different ones, but I'm not sure if there are any you recommend as primary. That depends. There are no specific go-to drugs for Pseudomonas. It all really depends on what the patient's situation is, what their allergies are, what their renal function is. All that stuff really goes into it to determine what drug is going to be best for that particular patient. But that being said, like, even resistance patterns where you're working at. If you're working in a place where the majority of Pseudomonas is resistant to the levofloxacin, then that's not going to be a good option for where you're working. So there's no true blue gold standard. Yeah, this is the drug you want to go with, but always keep in mind what your options are. Be able to make sense of like, what makes good therapeutic sense in terms of like mixing mechanisms and things like that, right? Okay. Yeah, actually, I do have one question. So I guess we'll talk about some of the test stuff right here. So because you guys have some questions before I get too deep into the endocrine stuff. So someone's asking here, if a patient with glaucoma has heart problems, would you still use a betaxolol, or would you switch to a non-selective beta blocking agent? Well, the question is like, well, what kind of heart problems are you talking about, right? If they have a history of, say, like second degree AV block, then really no beta blocker would be a good option in that case, because you could have a chance to exacerbate that. We're going to talk more about that in terms of hypertension management and different cardiovascular disease later on in this semester there. The betaxolol being a cardioselective one, that really only factors in if the patient has reactive airway disease, because you're going to be sparing the beta 2 receptors that are residing on the lungs, right? So remember, when I say beta, or when I say non-selective, that means it's going to affect both beta 1 and beta 2. If I say selective beta blocker, I'm talking about the beta 2 receptors being spared, and it's only going to affect the beta 1 receptors, which is primarily what you're going to find in the heart. you're going to have probably a higher concentration of beta 2 receptors in the eyes, so that's why the non-selective ones are more effective. But if you had someone with reactive airway disease, COPD, asthma, something like that, then betaxolol might be a better option for them if you needed to use that, right? Okay. So anyway, let's get back to it. Let's talk about our different endocrine drugs here. So with that being said about the negative feedback loop, again, being really important here. So we'll find some other chemicals can influence these systems as well. So for instance, we have a case here like hyperprolactinemia. What does this typically do to, you can have things like prolactin secreting tumors, things like that. You can have certain medications that can actually exacerbate this. So we'll talk about this when we talk about behavioral health and getting into our antipsychotic medications. You're going to find that typically there's a seesaw sort of effect between dopamine and prolactin in the body, to where if dopamine activity goes up, then prolactin activity goes down, and vice versa. If dopamine activity goes down, then prolactin levels tend to go up in those cases there. The problem here you run into, and this happens a lot with female patients, is that they can develop things like amenorrhea, they can develop infertility, and that's why frequently if you have someone who's having trouble getting pregnant, for instance, and one of the things you want to check out are going to be their prolactin levels, because you want to make sure that those aren't too high, because that can have a negative effect on their ovulation cycle and whatnot. So if you have too much prolactin level, basically what we can do is try to increase the amount of dopamine activity. And so by doing that, that then will pull back and drop down prolactin activity. Basically, by providing more dopamine activity, you kind of activate the negative feedback loop, and that's going to then help to shut down prolactin producing activity, right? The tumor, then you like to get rid of that if you can, but otherwise you can use medications. So this is where we can use what are called our dopamine agonists. And so there's a couple drugs here. These are under the umbrella of what we call the ergot alkaloids. We will talk more about this when we get to the neurotopics, when we talk about things like migraine and whatnot. Ergot alkaloids basically refers to a set of drugs that come as a derivative of a fungus. There's a fungus that actually produces these ergots. If you heard like ergot fungus or something, that's where these drugs are coming from. So another sort of natural source for medications. We have two here. We have bromocriptine and cabergoline. These are going to both work effectively for this, but you're going to find that the side effect profile isn't great. And so you can find things like a lot of blood pressure effects. You can have issues in terms of postural hypotension. So when they get up, they have a hard time regulating blood flow, especially back to the brain, which can cause dizziness and fatigue and even falls in older patients. So you do want to be careful there. But bromocriptine for sure, you probably most commonly used for like ovulation induction for patients who do have hyperprolactinemia. That's then going to help to drop those prolactin levels and hopefully allow for normal ovulation to occur again. We'll see these drugs come up again when we talk about Parkinson's in the neuro section next semester. So next, let's talk about our thyroid gland. So we see that with thyroid disease, you can either have issues of hypo or hypersecretion. And so it's important to know kind of where that is coming from. So is it going to be a problem to where there's a primary deficit or surplus? So either the gland itself is secreting too much or too little. You can see here for hyposecretion, oftentimes this is due to a lack of precursor, right? You can have secondary issues where this is going to be a problem with the pituitary gland, or you can have tertiary issues where this is more of an issue with the hypothalamus, right? Benefit here is that all three of these are going to be treated roughly the same, but you as a clinician have to kind of decide where the issue sort of lies here. And this is where things like lab tests can be useful. You can measure for things like T3 and T4, which I'll talk about in a little bit. TSH levels are going to be really useful here. And even patient history matters. I remember when I was in school, I was volunteering at the School for the Deaf and Blind in St. Augustine. We were doing basically summertime was ending, kids were coming back to school in the fall, and we were having basically as the kids were coming back to the dorm areas there, they had to have all their medications reconciled. What was interesting is that a lot of the kids who were blind actually were blind because of the fact that they had a tumor, like a pituitary tumor or something like that, that was very close to the optic nerve, that when they removed that tumor, then they also became blind at the same time. And it was interesting because because they're lacking that pituitary, we had to replace all these hormones they themselves were now not able to produce. So things like thyroid gland, things like growth hormone and estrogens and androgens and all kinds of things like that, because the pituitary is so important for helping to control all of those. But let's go and talk about the normal physiology here of what's happening. So again, here's your hypothalamus, here's your anterior pituitary gland, and then the thyroid gland itself. And you can see that negative feedback loop, how it all kind of works. Normally what you would be seeing here is that hypothalamus is going to be releasing things like thyrotropin releasing hormone that then releases thyrotropin, or TSH in this case here. So TSH is then going to have a positive effect on the thyroid to produce T4 and T3. Okay, T3 is going to be the more active form of thyroid hormone. T4, while floating around the blood, is not nearly as active, but it eventually gets converted into T3. So that's important to know there. And then as you have sufficient levels of T3 and T4, they will feed back and they will shut down further production of TSH in the anterior pituitary and TRH in the hypothalamus. If you're missing this, let's say for instance your patient is not producing much T3 or T4, this negative feedback loop never happens, and then that's why you end up seeing things like high TSH levels in patients who have hypothyroidism, because the pituitary is telling them, hey, produce more T3 and T4, but there's something that's preventing that from occurring, whether thyroid gland has been removed, perhaps it's been irradiated, perhaps they have a deficiency in a precursor molecule, where iodine is going to be coming up and becoming very important. And there's a lot of things that can affect this, either things like stress, you can have things like medications can affect this, all sorts of things are going to have different effects here, and so we're going to talk about some of those. So what happens in the actual production of T3 and T4 here? Here's kind of, I'll go over the steps in a few slides here, but basically what you're going to find is that iodine is a really important precursor molecule here, and of course I always get iodide and iodine mixed up here, but let's say for instance here is some of your basal cells within the thyroid gland itself. Basically iodine is going to get taken up here, and then there goes a step called peroxidation, where it basically gets available to undergo this conversion where iodine becomes combined with tyrosine, and it combines with something called thyroglobulin. It's basically like a transport protein of the thyroid gland. And then you're going to come up with a couple products called monoiodotyrosine and then diiodotyrosine. And the important point here is that they will then convert at different rates in order to form T4 and T3. Okay, T4 and T3, once it's made, can then be sent back through the cell and then released out into the bloodstream, where it can then go through and do its thing. So T3 itself will directly interact with the cells. T4 is not nearly as potent, but eventually gets converted over into T3 to kind of do its thing. Keep in mind, these hormones work just like all the other hormones we've mentioned before, like the corticosteroids. They float around, they go and get into the cells, they go down to the nucleus, and they then will change things like transcription of proteins and all that. So in general, you're going to find that very much like the corticosteroids, these are very powerful hormones in terms of having effects on things like metabolism and heat and things like that. But they take a while to work. So typically, if you're trying to replace someone who has hypothyroidism, this is the process where you're going to start them on a dose of something, and then you're going to have them come back in 6 to 8 weeks for lab tests to kind of see how they're doing. So this is not a quick fix for the most part, as we're going to see here. So as I mentioned, you have iodide trapping. Basically, you have iodide floating around your body that's been taken up from your diet, for instance, and then it gets transported into those follicular cells there, and it can be converted back into iodine. So it goes from iodide to iodine. I'm not going to ask you that on a test. I don't really care which state it's in. And then it undergoes that organification step, where basically it either forms monoiodotyrosine or diiodotyrosine. Picture what that looks like in just a moment here. I'll come back to that in just a second. Basically, though, what happens is that when you have two molecules of diiodotyrosine come together, two diiodo, that basically turns into T4. Now that has 4 iodides on it. If you have a monoiodotyrosine and then a diiodotyrosine come together, that forms T3. You have 3 iodides at that point there. You're going to see that the T4 is going to be produced in a higher degree. And so that's, again, what you're going to measure in the blood. You'll measure more of T4 than you will T3 generally for healthy patients, which is okay. That's kind of like a nice storage sort of form of it. When it gets converted to T3 and becomes more active, that's, when it's needed. And again, these steps here can be inhibited by different influencers. So for instance, here you can see that while iodine is really necessary in order to form T3 and T4, actually having too much of it can shut down production. right? Sort of its own little negative feedback loop there. And so that's actually one way you could see, for instance, if you ever were exposed to, like, say that there's like a nuclear bomb that dropped, right? And so say you weren't taken out in the blast, but you have all this radioactive iodine that's around. There's iodine 131, I think, is sort of the most prominent radioactive isotope after a nuclear blast. Well, one of the things you're going to find is that they recommend you take iodine tablets. I'm like, well, why do you take iodine tablets? Because if you take enough of it, it actually helps to prevent uptake of the radioactive stuff, which will then kill off your thyroid glands. Actually, a big problem patients who are survivors of nuclear events is actually hypothyroidism, because all that radioactive iodine can destroy their thyroid gland. So anyway, so the whole point there is if you have too much iodine, that can be a problem too, because that will then shut down production. So once the hormone is crossing back over into the bloodstream, again, it undergoes exocytosis, which just means it gets released back into the bloodstream. And then you'll have that T3, which is 3 to 4 times more potent than T4. And then T4, again, floating around kind of in the storage phase, can then be deiodinated into T3 in the periphery. Okay, this is another step that can be inhibited by high levels of iodine. And again, you can find that kind of occur in a couple different spots here. So it can either form the normal T3, or it can actually form this inactive form too, called reverse T3, which is not going to be important for us in terms of physiologic function here. You can see what a T4 molecule looks like. And again, this is T4 because 2 thiiodotyrosenes came together. Notice here 1, 2, 3, 4 iodine molecules here on thyroxine, another name for the T4. And they can either form normal T3, which is our triiodothyronine, this is the active form here, or it can form this reverse T3, which is not active and just gets eliminated through the body some way. So what can we do for these patients if they're not producing enough of their own thyroid hormone, right? So they have hypothyroidism. We can basically replace the thyroid hormone that they are missing. And so there's a couple ways we can do that. And so we can either supply them with T4, we can give them T3, or perhaps give them a mix of the two that is going to be more similar to what the body's natural levels sort of are, okay? As I mentioned with thyroid hormone replacement, this is not a quick fix. We're not really needing to get the patient, few people die from hypothyroidism. Most people coming in are not going to be so symptomatic to where you're really concerned about that, right? But, it causes fatigue, and people have, inattention, and they're cold, and their metabolism slow, they're gaining weight. And, so there's a host of problems with it, none of which are generally immediately deadly. So it's okay if this takes a while to fix, right? It takes weeks, 6 to 8 weeks usually between dose changes, just to see how the drug's going to work. Which is why, most frequently, it's okay if we just give T4. So this is going to be the most common one we're going to see being given here, because it's okay if it takes a while to work. This is T4, which is, the less active form, but it's okay because it gets converted over into T3 in the body anyway. So if you see like Synthroid, this is what we're talking about here, which is the majority of hypothyroidism patients are going to be on this anyway. And so this is kind of your drug of choice here. But again, it's going to have pretty consistent potency here, but a prolonged duration of action. So the effects stick around for quite some time there, which is nice. You'll find that most people take oral varieties, but there are some parenteral that are available. I see this most frequently for patients who are actually have undergone brain death and are getting ready for organ transplant. You'll see that people will utilize IV levothyroxine to try to make sure to maintain normal thyroid hormone levels for those patients there. Anyway, big things to note though in terms of like drug interactions here is that things like iron, calcium, and aluminum can interfere with the absorption. So just like we saw with the fluoroquinolones, how if you have like calcium combined to the drugs in the GI tract and prevent it from being absorbed, this can do the same thing. So make sure they're separating out their thyroid hormone from other things like iron containing multivitamins or milk or things like that, okay? Other issues you can run into here include things that like induce the P450 system. So for instance, certain anti-seizure drugs can do this, can actually reduce levels of T4, can get rid of it too quickly, and that can also kind of worsen the hypothyroidism. So do want to be careful there. And in some cases, we also use this for suppressive therapy. So for instance, if we have a patient who is, say, maybe they have like a pituitary tumor, and they are producing too much TSH, for instance, you could use it as suppressive therapy because this will still satisfy that negative feedback loop and feedback and shut down production of both the hypothalamus and the anterior pituitary in those cases there. So a couple different ways you can use that. Now, if you want a quicker action, you could use something like liothyronine, which is just T3. And so if you wanted the onset to be faster, like maybe, you know, a couple days or so, this would kick in much quicker because, again, this is the active form. However, it's more expensive. You know, the onset's going to be a little more sporadic. So you'll find that relatively few patients are actually taking this form here. Some people like to have a more natural sort of ratio, you know, form they'll take. So here's an example of Liatrix, which is a mixture of 4:1 of T4 to T3. Again, no additional clinical benefit over something like Synthroid. So few people are on this, but you may find some specific cases where it's useful. You'd have to ask an endocrinologist. I don't know what they are. So what are they going to be used for? Typically, well, most cases of hypothyroidism. So either due to things like Hashimoto's thyroiditis, where you have this autoimmune destruction of the thyroid gland. Maybe people who have had thyroid cancer and have actually had the thyroid gland removed or been irradiated in order to kill off those cancer cells. They can't produce their own thyroid hormone anymore, and so we need to replace it. And so then at that point, it'll be a lifetime drug for those patients there. So, and again, the actions of this is going to be the same. They're going to be working just like the natural forms that you're producing. They will get into the nucleus of the cells where they need to work. And again, these are affecting cells all over the body. Can affect the muscles, can affect the fat, can affect everything. And then they will then get down to the nucleus where they can affect different targets in the DNA, either shut down or upregulate transcription of certain genes, which then leads to protein production changes and all of that. So just like with the corticosteroids, the mechanism of action is identical. It just matters in terms of like where they're actually binding to within the actual cells themselves, or within the DNA. The targets are different there. Now, as an alternative, we can have some drugs that help us out for patients who have hyperthyroidism. So if we wanted to decrease activity of T4 and T3 in the body, we can do that as well. And so we have two main drugs here. So these are called the thiouracils, or the thioamide family. Two drugs fall into this. We have propylthiouracil, those known as PTU, or we have methimazole or tapazole. And so you're going to find here that either of these are going to be pretty effective in order to help reduce down levels of T4 and T3 being produced in the thyroid gland. Now, again, this doesn't do anything directly to the circulating T4 and T3. It is only going to work on the production of T4 and T3. So very similar to how something like warfarin took a few days to kick in and take effect because it didn't affect any of the circulating clotting factors. It only affected the production of new clotting factors. Very similar here, where you're going to see that it's going to take some time for it to really kick in. Some risk for things like agranulocytosis, which can obviously put you at risk for infection if you lose all your granulocytes, but this is relatively rare. How are these drugs going to work? Basically, they interfere with the oxidation step of iodine, and they'll interfere with the organification step here, basically preventing the two steps in the process of actually producing the diiodo and monoiodotyrosine in the first place. And so, again, you have to have depletion of iodinated thyroglobulin beforehand before the effects even become evident, right? So, again, getting rid of the already formed precursors before these drugs will actually do their thing. Where do we use these most frequently? This is things like Graves' disease, where you have, again, a different autoimmune disorder from Hashimoto's, where basically you have stimulation of the gland due to these TSH-looking sort of antibodies here. And so and we can also use it for things like goiter. Sometimes if you have a patient who has significantly enlarged thyroid gland, you can actually help to shrink this down by decreasing production of the actual T4 and T3 itself. So again, just like with any tissue, if you take away the thing that is enhancing its growth, then it will then start to shrink down. There's other things we could do too to treat hyperthyroidism, and this actually includes iodine here. So I kind of mentioned this before. Now, I talked about radioactive iodine, and this can actually be used for therapeutic purposes. So if you have someone who is, for instance, having thyroid cancer and you want to get rid of those cancerous cells, this is where radioactive iodine can be useful here. So for instance, basically what happens is iodine is mainly taken up by thyroid cells. That's just where store of it's going to be. And so you can actually give a patient radioactive iodine that will be preferentially taken up in the thyroid gland. And when that iodine sits there, it releases things like gamma and beta particles, which kills the surrounding cells. And so that's why it works for what we call radioablation with radioactive isotopes like this. There's other kinds you can use for scans, for instance. But the big problem here is you're going to see a very high incidence of delayed hypothyroidism, which makes sense. Again, it won't be an immediate effect because it doesn't do anything to circulating T3 or T4, but it kills off the cells so that way they cannot produce any more T3 or T4. That's why it takes a while to kick in. But it can be useful if you have someone who has thyroid cancer, for instance, here. Other things we could do, though, is we can actually give someone high levels of iodine of the non-radioactive variety, and that can actually help to shut down production of T3 and T4 as well. So we can give something called a saturated solution of potassium iodide, or another one called Lugol's solution, which is just really concentrated potassium iodide. And basically, you can use this for hyperthyroidism as well, where you could use this in conjunction with things like PTU and methimazole, and basically use this to help shut down further production of T3 and T4 by giving so much iodine that the gland says, okay, well, we must have enough T3 and T4 around, so let's go ahead and just shut down further production there. Can also help prior to surgery as well by shrinking down the gland itself and decreasing vascularity, which is nice. In terms of complications, you can have what we call iodism, which is having too high of iodine levels, which can cause things like swollen salivary glands, can be kind of painful, mucous membrane ulceration. So obviously, you definitely want to warn patients about that. Okay. And as I mentioned, you can use it prophylactically when exposure at risk for radiation exposure. So, for instance, if you watch the show Chernobyl on HBO, if you have that available, there'll be some mention of using iodine as a protective sort of agent there. So, pretty interesting stuff, I think. Radioactive accidents and whatnot. Here's another one called, it's an iodinated contrast media called ipodate. You'll sometimes see this used in radiology in order to help get different scans done and things like that. This is actually useful in terms of treatment of what we call thyroid storm. This is where patients who have really high levels of thyroid hormone can cause thyrotoxicosis, causing increased blood pressure and heart rate, and it can become cardiovascularly unstable when you see this. And so even though it's not FDA approved for this, it is still sometimes used in order to manage this. It's more of like an emergency room ICU kind of setting. And so you can actually use this to help inhibit the conversion from T4 to T3. This is useful because we mentioned T3 is the more active form. So if you prevent that conversion, then you can overall decrease the activity of T3 in the body, which is pretty handy there. And again, it's used in relatively short courses, so it's pretty non-toxic for the most part, over the course of hours to days maybe. Not like a chronic medication they're going to take here. As I mentioned, pretty helpful in terms of treatment for thyroid storms. If they have elevated temperatures, cardiac overload, very handy for that. Okay. Moving on from our thyroid gland, let's talk about adrenocortical insufficiency. So we've talked about corticosteroids prior to this, right? So we've talked about their in use for inflammatory conditions like, if you have bad sinusitis and you're having a lot of nasal congestion and maybe some shortness of breath and all of that, corticosteroids can be useful for that. And so we've talked about different activity here. So we talked about glucocorticoid activity and we talked about mineralocorticoid. Important to get these two separate in your mind because they have very different actions. So when we talk about corticosteroids in the past, we've mainly been talking about the glucocorticoid action because this is where we get the anti-inflammatory activity here. This is where we talk about effects on glucose, like causing hyperglycemia, talking about things like mood changes you might see in patients who are taking glucocorticoids. All those nasty side effects, for the most part, come from the glucocorticoid side of the drugs. On the other hand, though, you can have some mineralocorticoid effects here. When you see this, I want you to think mineral, I want you to think salt, I want you to think about salt and water balance in the body. And so the primary one we have in our body is aldosterone. And so you can see here that they are important for causing water retention and salt retention. We'll get into this more when we talk about the cardiovascular drugs coming up here in a little bit. And so basically, that's why you end up seeing a lot of the corticosteroids we have, like hydrocortisone, dexamethasone, prednisone. They have a little bit of both. They have glucocorticoid and mineralocorticoid activity, which is why you saw that things like edema, fluid retention were a common side effect of those drugs. It's because of this aldosterone-like activity, because they have some activity at mineralocorticoid receptors. Okay, so again, naturally your body produces cortisol, which is hydrocortisone, and you can see here that you secrete about 10 to 20 milligrams a day, and it follows sort of a circadian rhythm there. So there's certain parts of the day where you have higher levels, and other parts of the day you have lower levels. You're going to find that things like increased stress, are going to increase release of that. That's why you can see patients who are chronically stressed have higher blood sugar levels because of the glucocorticoid effects of that. You can see patients who are physiologically stressed have fluid retention because maybe you need higher blood pressure to deal with whatever that stress is, if it's something chasing you or something like that. So a lot of effects you can see with this. Some of you all may be experiencing this being in PA school, right? So focusing more on the mineralocorticoid side of things here, here's an example of a disease state which causes mineralocorticoid insufficiency, always known as Addison's disease here, where basically you can find that they have a lot of issues in terms of fatigue and weakness, weight loss, and hypotension. A lot of that is due to fluid loss, because if you're missing aldosterone, then you're not holding on to that water and salt as much, and so you just end up peeing a lot of that out. And so that can be a bit of a problem there. And so they have this inability to maintain good glucose levels as well, which is an issue, obviously. And if they have acute adrenal insufficiency, they can develop circulatory shock and death. We would have some patients who would have sort of chronic adrenal insufficiency, and anytime they got physiologically stressed, their body couldn't respond by increasing cortisol release, and that ended up leading to them having severely profound hypotension because and hypoglycemia, just because they could not control it, either of those. And so they went ahead and we'd have to give them replacement steroids as they came into the ER. Hypotensive and hypoglycemic got to be a bit of a challenge there for sure. Okay, I was just checking back in on your exam. So exam is definitely going to be 8 tomorrow. Just FYI, I got feedback from Kelly there, Professor Kelly. So anyway, so typically what you're going to find is that a lot of these patients are going to require replacement of hydrocortisone for this adrenal insufficiency here. And so we'll give them sort of like a daily amount. And then if they get stressed out, so say like they're a kid and they're in school and maybe they get bullied or something and they get physiologically stressed, you can have what they call stress dose hormones, where you can go ahead and give them the bigger doses in order to help kind of overcome what they're kind of missing their body normally would have released there, which is handy. We often will also give them a salt-retaining hormone, and this is called fludrocortisone. This is basically a hormone that only has mineralocorticoid effects, so really acting as a replacement to stuff like aldosterone, and so it can help to maintain their blood pressure better by holding on to salt and holding on to water, which is very handy there. Okay. So moving on from there, next we're going to have our androgens, and so this is kind of the one spot where we can talk about male hormones. We'll talk about female hormones, has its own section later on. Unfortunately, you're going to find that, you know, for the guys, we're just not that complicated as opposed to the females, you know, just from a hormone standpoint, it's just kind of how it is. And so we're going to spend a little less time talking about the male hormones who are the female hormones, but you actually are going to find they have a lot of interplay with one another. You're going to find there's a lot of crossover effects that you can see because your body, whether you're male or female or whatever, you know, your physiology is, there's a lot of crossover here because there's conversion between all these different hormones. And if you notice here, they all kind of share the same sort of steroid structure here, the same sort of 4-ring structure here. It's just a matter of what changes on the sides here, whether there's hydroxyl group or an ester group or whatever the case may be. Again, you don't have to draw these on the test, but the main point being is that these are all coming from the same precursor of cholesterol, right? So I'm getting these emails in from Professor. So yeah, it looks like 8 o'clock, yeah, because you guys have lab at 9, so we're going to do 8 o'clock tomorrow. But anyway, so cholesterol is going to be a precursor molecule here that gets converted over in pregnenolone. And then you can see here that some of that will be turned into cortisol, which we were just talking about as being hydrocortisone, your main stress sort of hormone there. We'll see some of this can be converted into progesterone, which is going to be important for our function of the ovulation cycle and the menstrual cycle here a little bit later on. And then some of this may be converted to aldosterone, which will be important for cardiovascular function. We'll see a little bit later on. And then this can be converted into testosterone and then into estradiol. So it's interesting here because you can have patients, say for instance, female patients who have things like PCOS, who may have issues where they're producing too much testosterone, but not enough of it is being converted into estradiol. So there's a very delicate interplay here between these different hormones and what's being produced and what sort of effects you're going to be seeing in your patients, right? Also think about things like transgendered patients who may be on hormones to try to either facilitate further production of certain hormones or maybe blocking production of certain hormones. So there's a lot of ways we can interact with the system here many of which we're going to be talking about as we get into it. But just know that there's a lot of interplay here. And when we give drugs to supplement some of these things, you can see a lot of bleed over effects here, right? Because not all of these are completely selective for their own specific receptors. There can be some cross reactivity. So for instance, one of the things you'll find for a lot of female patients or patients who go on oral contraceptives that contain estradiol and some sort of progesterone is that frequently they get fluid retention and weight gain as a result of that. And that has to do with the fact that there's a lot of crossover here with aldosterone, which we saw has a big effect in terms of holding on to water and salt. So it gets fairly complicated here, and I'm just mainly going to be focusing on the androgens that we can produce and ways that we can affect that system, either by replacing it or if we can find ways to actually decrease production depending on the situation. A lot of ways you can play with this. And again, these are hormones, so they have really kind of body-wide effects, very strong effects you're going to see in the body. They do take some time, though. But let's look at some of these things that pop up here. So testosterone is going to be the main sort of androgen produced in the testes by your male patients. You produce about 8 milligrams per day. What's interesting, too, is that testosterone, you think about, like your T levels and think about this as being, it caused all this kind of masculinization in patients here, but it's actually not nearly as potent as something called dihydrotestosterone, DHT, if you ever see that, dihydrotestosterone here, which is actually a more potent form that is converted by an enzyme called 5-alpha reductase. This is the most major active component here, right? If I give someone testosterone, it's all well and good, it'll have some effects, but it's much more potent when it gets converted into DHT by this enzyme called 5-alpha reductase. This is the big one here. Once testosterone is formed, or if you were to give it exogenously, it can also be converted via an enzyme called aromatase to produce estradiol. This is a very important step for patients who either are, maybe they have too much estradiol, maybe they have cancers that are being sort of upregulated by things like estradiol. If we want to block that, we can do things like aromatase, block aromatase activity, and that can actually lead to higher levels of testosterone. So delicate interplay here. We're going to look at all of these here in just a little bit. The other big thing you're going to see too is that most of these hormones are going to be metabolized in the liver, and this will become important for some of the side effects here we're going to see with our androgens in just a little bit, right? Keep in mind there's a difference between androgenic, means effects of androgens, versus adrenergic. Adrenergic is more referring to things like adrenaline, like epinephrine, the adrenal glands, things like that. So just kind of keep the two in your mind here separate. And again, these work just like all the other hormones we've seen. They get down into the intracellular receptors on the nucleus, and then they will affect gene transcription. Okay. And these undergo the same negative feedback loop that you're going to see, like what we saw with the thyroid hormones. Same thing happens here. The hypothalamus is going to be releasing gonadotropin releasing hormone, which then stimulates the pituitary gland to release two hormones here called luteinizing hormone and follicle stimulating hormone. These are actually, this step here is the same in male or female patients. It's going to be the same regardless. And then it just matters of what organs the patient has to affect. If they have ovaries, those will be affected. If they have testes, those will be affected. If they have both, then both will be affected, right? You're going to find that LH and FSH will then stimulate the testes to produce a few things, one of which includes testosterone, which we're mainly going to be talking about here today. It can also affect sperm production and inhibin, right? Testosterone can then have a negative feedback loop, which can then shut down further release of GnRH or LH and FSH, usually both here. And so, which is interesting though, because imagine if I were to give someone exogenous testosterone, if I was to give them extra out here, again, this is going to then still activate the negative feedback loop, so they will actually shut down production of their own testosterone. What's one of the like side effects you hear about with like, say, like bodybuilders who are using a whole lot of exogenous androgens? Well, they usually have testicular atrophy, and a lot of that is because they have then shut down production of things like LH and FSH and GnRH, which normally stimulate the testes to grow and to actually produce things like sperm production. So you'll hear about infertility and testicular atrophy as a result of abusing exogenous testosterone. Kind of interesting. There's also a thing called inhibin, which is produced, which will also feed back and inhibit the pituitary gland, but this is less clinically important for our purposes today. So we can see that we can just replace it with natural testosterone. If you had someone who had low testosterone levels or say you had a patient who was transitioning from female to male, you could utilize exogenous testosterone itself. And there's a lot of different forms here. You're going to see that we have mostly either injectable forms, or these are going to be topically administered. And so there's just a ton of different varieties here. Some of them come as like long-acting injectable forms. Some of these, as I mentioned, are topical forms you can apply directly to the testes, all kinds of different things. So the different brand names are really not so important, but just know that this is the main thing we're using here is just testosterone itself, right? And then once it's absorbed, it can then be converted over to DHT by 5-alpha reductase. Again, this is the important enzyme that converts T to DHT. And this is the more active form here, right? Now, there are other varieties of synthetic androgens we could also administer. So either ester forms or alkylated forms of testosterone. So things like methyl testosterone or fluoxymestrone or oxandrolone. There are certainly many more that are out there. If you were to go and peruse any sort of like bodybuilding forum or something like that, you'd find all sorts of different hormones being talked about there. These are the main ones you'll find being used potentially as sort of testosterone replacements from a medical standpoint, not necessarily from like a more athletic or enthusiast sort of standpoint, you know, which are maybe done either within or without or outside of the scope of the law, but I won't get into that too much. Main part here is that a lot of these PO forms of steroids are going to be really, really rough on the liver. And we'll talk more about that in just a moment, but generally speaking, PO androgens are sort of not recommended in most cases. We either want to stick with one of these transdermal or injectable forms because it's going to be really tough on the liver if you take PO varieties here. Okay. Now, what are the physiologic actions of the androgens? Well, they can stimulate the androgen receptors within the nucleus, and so it's going to cause a lot of the masculinization sort of effects here. So it's going to provide growth of things like the internal genitalia. It can affect the skeletal muscle to grow. It can stimulate erythropoiesis, so you can actually stimulate red blood cell production. And you'll also see with DHT, you get a lot of things like external genitalia being formed here that are stimulated, like in terms of growth, hair follicles. So a lot of like the male pattern of hair body distribution you're going to see as a result of DHT. You'll see things like the prostate will be stimulated to grow, which can lead to things like BPH in older gentlemen, things like that. But remember, some of that testosterone gets converted into estrogen by that aromatase enzyme. And so you can also see that this can affect things like the growth plates on the bones can actually end up closing those early potentially. It can lead to changes in libido and whatnot. So again, doesn't matter how you administer it, some degree of that androgen you administer, like testosterone, will get converted over into estrogen, which can have some estronizing or feminizing sort of effects there, right? So what do we use androgens for? Well, we can use them to replace low levels of testosterone. Maybe they can't produce it because they had testicular cancer and had those removed, right? They can replace what they're not producing anymore. You can use it in some cases of things like osteoporosis or certain types of cancers and whatnot. So it really just depends on the situation there. And again, just seeing here whether you're using testosterone or some of the methyl forms, which I mentioned are the oral forms we'd like to avoid if possible here. But things like male infertility, you'll see that sometimes for osteoporosis. And again, this is helpful because it's an anabolic hormone, right? It's helping you to build up the tissue. And so you can see this to help with weight loss, can help to put on weight, right? So if you have patients who have longstanding AIDS, chronic diseases, if you have burns and trauma, they can sometimes be used to help kind of bulk the body back up to what it was like before the disease state sort of kicked in. So it really just depends on the situation, where you're trying to use it. Sometimes we'll use what we call anti-androgens in order to kind of prevent some of these androgenic effects. So if you have something like prostate cancer, where things like DHT are stimulating the prostate to continue to grow, you can inhibit that by using some sort of anti-androgen sort of drug, which I'll talk about a few here in just a moment. Or for things like hirsutism in women, right? So if you have women who are producing too much testosterone and not enough of that is being converted to estradiol, then you can end up developing some of that sort of masculinizing effects in terms of like body hair distribution. So you can see things like, you know, hair growth in the upper lip, for instance, and things like that. Those are related to hirsutism. So as I mentioned, that the forms I talked about before, the oral forms of testosterone are generally not useful for oral administration, which is why we come up with those alkylated forms of things like methyl testosterone. Otherwise, if we're giving it via injection or transdermal, then you can use testosterone itself, no problem. Either it uses like a transdermal product, which can be actually applied directly to the testes, or in some cases, even injectable forms that come in an oil that allows it to be injected into the muscle, and it will just kind of sit there and release over a slow period of time. So a lot of different ways this could be administered. On the other hand, though, here's some anti-androgens here. And so I want you to think about what sort of effects you might actually find by giving an anti-androgen. So if I'm blocking the effects of testosterone, you can end up seeing a higher kind of a shift over to more effects of estrogen in those patients there. So if you have someone who's taking anti-androgen, you can actually find the feminizing sort of effects of estrogen tend to take over for those patients there, which may be a good thing, maybe a bad thing, depending on the situation, right? So for instance, here with androgen receptor antagonists, we have things like flutamide or bicalutamide. These directly block the androgen receptor itself. Maybe useful in some cases of things like prostate cancer if you wanted to block the effects of DHT at the receptor itself. We're going to talk a lot about spironolactone, which I think we already talked about in terms of its use for acne before. But if you recall, spironolactone is a partial androgen receptor agonist. And what you're going to find here is that for some patients who have high testosterone levels naturally, spironolactone being a partial agonist will help to kind of bring overall testosterone activity down, versus someone who has a low testosterone activity, say like a female patient who produces a lot of estrogen. This will actually end up bringing androgen level activity up. So for males, you can actually end up seeing a sort of feminizing effect where you get things like breast development, gynecomastia. For female patients, you actually can end up seeing things like more masculinizing effects like hirsutism that can develop from use of spironolactone. So again, it's kind of a mixed bag depending on what your patient's baseline testosterone activity is in the first place here. Right? Here's another one called cyperterone, which is sometimes used in cancer causes. And then we'll talk about this in urology later on, but there are drugs we have that actually block conversion of testosterone over to DHT, and we use this a lot for BPH. So this is more of a urologic drug we'll see most commonly, but something called finasteride is very handy at doing this. Now again, there's a lot of side effects of using the androgens, like you might expect from having extra testosterone activity. So things like prostatic enlargement, prostate cancer are certainly risk here because that will directly stimulate the prostate to grow. You'll see testicular atrophy and azoospermia. So again, infertility is very common while patients are taking exogenous testosterone, especially not necessarily if they're just like taking something to replace what they're missing, but if they're taking super therapeutic levels or super physiologic levels. So you see this a lot in patients like who are bodybuilders who are using this for anabolic effects. Gynecomastia, again, not all of that testosterone stays testosterone. A lot of it gets converted, or some of it gets converted into estradiol. So you can see some feminizing effects from these drugs here, right? So you want to think about that. Erythrocytosis, you may see this more in patients who have relatively low levels of hemoglobin to start with. Not seen in most male patients who are taking this. You'll certainly see increased sodium and water retention because there is some crossover effects with aldosterone, and that may be bad for patients with heart failure where they may have volume overload to begin with. Okay. Now this is an important one for the oral varieties that are the alkylated forms here. Because they are taken orally, they get processed through the first pass and they get processed to the liver. And so this is important because they cause a lot of effects, causing cholestasis, cause hepatitis. They can cause effects on your cholesterol. So definitely watch for that. Definitely, that's why a lot of people who are using exogenous steroids avoid the oral forms altogether because they can cause pretty significant hepatic effects there. Less often seen with the injectable or transdermal form. And of course, you'll see masculinization in female patients. So you can see things certainly like muscle growth, but also you can have deepening of the voice. You can have hirsutism. Acne may be worse for them. You know, it just depends on sort of what their baseline level were in the first place and kind of where you're taking them by supplying exogenous androgens, right? So, and again, some of these may be good effects if they're looking for that. So if you had like a transgender patient who's transitioning, if you have, there are female bodybuilders who utilize testosterone-based products. I mean, so it just depends on the patient and kind of what their purposes are, how they're using these things here. And again, you're like, well, you know, they shouldn't be using this for bodybuilding purposes, but you're going to run into patients who are taking this stuff outside of the confines of the law, and you still need to be familiar with it, still need to be aware of it. Maybe you educate based off of that, for instance. I mentioned you can have the DHT, basically the 5-alpha reductase inhibitors that block the production of DHT. This is going to be used a lot in benign prostatic hypertrophy, which we'll talk about later on in the urology section, probably next semester, I think. But this includes finasteride and dutasteride. And then you can actually even give GnRH analogs. So a couple of drugs like goserelin and leuprolide, these actually can help to either stimulate production of GnRH. As low levels, you're going to see this actually helps to stimulate the anterior pituitary to start producing FH and LSH. Or actually, in some cases here, we can give super therapeutic doses, and this can actually shut down production of GnRH and LH and FSH by kind of overstimulating the hypothalamus. It really all just kind of depends on how you're using these drugs here. So these are used occasionally, especially like for cancer purposes and things like that. You can see basically from the hypothalamus down to the anterior pituitary down into the actual testes itself, how kind of the different negative feedback loops can occur here. So for instance, like spironolactone is going to have a negative effect here. The finasteride is blocking 5-alpha reductase, converting testosterone over to DHT. Things like flutamide blocking the androgen receptors themselves. You can see how all these things are working here. And again, using GnRH agonists or antagonists, you can actually cause changes in production of LH and FSH as well. So it really just depends on where you're working at in the cycle here in terms of what overall effects you're going to be end up seeing. Okay. Anyway, that's it for this section. Let me know if you have any questions, and I'd like to take the rest of this time to see if you have any questions regarding the exam. Again, it's going to be 8 o'clock tomorrow, so just confirm that with your campus director. So FYI on that. So it'll be bright and early. Make sure to set the time for the exam. It'll be, I guess you guys will be on campus or use Respondus. I set up so you'll see the wrong answers when you're done. You only can see it that one time. 50 questions, 4 answer choices. And again, I'm going to warn you now, all the questions, majority of the questions I ask are just going to be giving you either a simple question or it could be like a vignette. And it'll say you have this type of patient, here's their past medical history, here's what drugs they're on potentially, what drug is going to be best for this type of patient, or what drug might be contraindicated, things like that. And then you're just going to have 4 drug choices, right? I don't say like, I don't say prostaglandin, beta blocker, carbonic anhydrase inhibitor. I give you the drugs from those classes. So if you can't link metaxalol and identify that as a beta blocker, and then say, okay, well, what do I know about beta blockers? What side effects do they have? How do they work? You're going to have a tough time with the test. Okay, that's a challenge I'm seeing with a lot of students here, is being able to link back individual drugs to their classifications. Can't do that. I would recommend start to looking into that. It's kind of 11th hour, but that's okay. Better late than never, I say. That can definitely help you out. Looking at the sticky board, I don't see any questions here, but if you have anything, post them up in the chat. Post them on the sticky board. Only got 23 of you, so I'm assuming everyone's watching either in a group party or something like that. But all right, so Savannah's asking, are macrolides the first line treatment for bacterial conjunctivitis? Not necessarily. You'll see, depending on the patient there, something like sulfacetamide could certainly be used. You can get away with using a macrolide like erythromycin pretty commonly. It really just depends on the situation there. Typically, I would say don't use your fluoroquinolones or your aminoglycosides as first line for anything unless you're really worried about Pseudomonas, right? So if they have like a history of like contact lens wear and you're worried about bacterial conjunctivitis and you think Pseudomonas, then utilize something like a fluoroquinolone, right? What other questions do you guys have? Sorry for my creaky chair. No problem. Either some of you are like, I already know all this stuff. I don't have any questions. I got it down pat. We were like, I don't even know what I don't know. More concerning, but I want to make sure you guys feel comfortable going into the exam because, again, it's going to be more, it's all drugs, right? So we kind of got through the fundamental stuff last time. It's all drugs this time. What other question you guys have? Again, you can email me today. If you get it to me earlier, I'm more likely to answer it. If you email me at 1 o'clock in the morning, I probably will not answer it. So your probability of getting a satisfactory answer goes down as time gets later on in the day. Nothing at all. Okay, well, if you guys got nothing, then I'll stay on for a few minutes just to see if anyone's posted up questions, but otherwise you are free to go. You have a good day. The exam will be at 8 a.m. tomorrow. Coming on campus, and you'll use the lockdown browser just like we did last time. You guys have a great week. You have your feedback on the prescription assignment, so that's all done. Make sure you get the next one in. I forget what due date is that for, but you'll see it on there on campus, or on Blackboard, I should say. We'll go from there. Thanks a lot, and I'll see you next time. Yeah, so in terms of valacyclovir, yes, it does have higher bioavailability than something like acyclovir, which is why it's preferable when given orally, right? Because it's a prodrug, so it's inactive when you first give it, and then it gets converted over into the active form after it passes through the liver and undergoes that metabolism. So it doesn't make sense to give it intravenously because of the fact that when you give something IV, it has 100% bioavailability, right? So I can give IV acyclovir and get 100% bioavailability. There's no benefit to using valacyclovir. If anything, that would slow it down, its actions, because it would have to wait to be circulated through the liver to be activated in the first place. But again, I'm not going to ask you specifically like which ones are available IV versus PO. It's more so of like, what's the benefit of using something like valacyclovir over acyclovir, and you would say, okay, because I know that it has higher bioavailability when given orally because it is a prodrug and has first pass metabolism, for instance. What other question? I'm just assuming you guys are all super geniuses and you just know everything already, so I think that's a healthy assumption, right? That's why this stuff is easy. Why am I even here? I don't even need the lecture, right? All right, well, I'm not hearing anything, so I will go ahead and cut it off. But again, email if you have questions. I will not be checking the sticky board until next week, so just if you post it there, I will not see it. Otherwise, I will see you guys next time. Have a good one.